Yeah, good afternoon. Myself, Dr. Rishikesh from Hiranandani Hospital, Mumbai, and with me is the Dr. Nasu. Actually, the live case, which is supposed to live telecast, we finished it much early, and there was another primary angioplasty case was there. So we have been discussing the case with already everything ready with us. So I will shortly cover the history. So our patient, 73 years old male, hypertensive and diabetic, old history of CA prostate. He underwent a chemo radiotherapy 9 years back, termed as cured. History of chronic stable angina, and now recent symptoms in the last 2 to 3 months. He underwent an angiography in 2008, which that time suggestive of RCA total and LAD 30 to 50% lesion, and L6 being non-dominant, having critical disease. In 2017, he again underwent angiography, which revealed more or less similar picture with slight progression of LAD disease. The 2D echo wise, his LV function is fair. The estimated GFR is 37 ml, and our plan is IJCTO with complete revascularization. So, just to show the 2017 angiography pictures. So, we can see the LAD proximal, osteoproximal calcific borderline lesion, 50 to 70%, ramus being a major vessel, minor insignificant flux, and L6 being a non-dominant vessel, mid diffuse disease. The RCA, we can see the proximal total, and the distal RCA is filling from left system of Rentrop grade 2, and also from the antegrade with bridging collaterals and with RV branch faintly. So now I hand over to Dr. Nasu. So how we proceeded?
Okay. So you know that this case is at least 11 years old. So that's meaning that usually decolonization is not easy. This is today's angiogram. So you can see the 50%, almost 75% of the stenosis just orifice LAD, but the collateral filling through the septal to the PD branch very, very less. We cannot see the promising channel in areocranial view. So this is areocaudal view. Areocaudal view also
we cannot see the angiogram.
We cannot see.
Okay. We cannot see the angiogram.
Okay, could you change to the angiogram? They cannot see the angiogram. Did you see? Oika-sensei, can you see?
No, not yet.
No.
There are no pictures.
No, they cannot see the angiogram.
Okay, we can see.
Okay.
It's okay?
Yeah. Yes.
Okay, this is the first shot from the areocranial. So you can see the 75% of the stenosis just orifice LLE, but we cannot see any collateral channel through the septal to the PD branch. This is areocaudal view. So the areocaudal view is the same. And this is a Shine without contrast. So you can see the calcification. This is very good landmark to the wiring. So I checked the Shine angiogram without contrast like this. And then checked the Shine. So you can see some microchannel or some breaching ipsilateral collateral through the PD RV branch. So of course I checked the areocranial view. So this is areocranial view is a Shine without contrast. So you can see the very good, very severe calcification, but this is a very good landmark to know the vessel course. So this is injection. So we can see the some flow through the ipsilateral channel. Some branches overlapped with the areole, inner areoles. So, but actually, I think the CTO length is not so long, less than 1 centimeter or something. So could you discuss the strategy about this case?
I think there is perhaps a micro channel. I might try first XT or XTR. If I'm lucky, maybe I can go through. And if it doesn't, then go to wire escalation, some Gaia 2 or things of like that nature.
Well, actually, I pushed the wire to the branch and the chip injection from the microcatheter. But unfortunately, there is no microchannel. This is aerial view. So you can see the almost no stamp the orifice. So you cannot see any microchannel inside of the CTO side. So anyway, this case is no red option.
Nasu
So I studied with the undergrad, of course. So can I? Yes.
From our diagnostic catheterization findings, we can see some tiny channel from first septal channel to 4PD. No?
Yes, sure. Yeah, actually, in 2008, in the angiogram, the collateral, not good, but some collateral connection through the septal to the PD branch. So if we need to the red approach, we should check the chip injection from each septal.
Okay, understand. But this patient has a moderate CKD, less than GFR is less than 40.
Yes.
That is why
Yeah.
sometimes we consider the red approach for the CKD patient.
Yes, of course, but my concern in the elderly osteal stenosis, so we use the red approach from the septal. Maybe we should fix the LED orifice before the red channel negotiation.
Yes, I agree.
So
I agree with you.
unfortunately, we can see the vessel course. So I started the undergrad approach today. Can I go ahead?
Yeah, please.
Yes. So I use of course, I want to see the orifice by the IBUS, but this is volcano. I could not go the proximal bifurcation because of the calcification. So I gave up the IBUS examination to identify the proximal cap of the CDO. So I used the dual lumen caster Sasuke. And I started from this is Gaia second, to negotiate inside the channel. Actually, this is the Gaia second could go very easily inside the CTO side. And then I changed to the microcaster from the dual lumen caster Sasuke to the Corsair. So now Corsair has come to no. So yes, now Corsair is there. So I continue the wire channel negotiation. So
Dr. Nasu, we need to go
wire
to
is
SPGC, the Sanjay Gandhi Institute for the other case. We'll get back to you after 10 minutes.
Yeah, Dr. Nasu, you take over.
Okay, this is Gaia second. I managed the guide wire carefully that we can use the calcification as a landmark for the undergraduate wire. Finally, this wire second can go down so very easily like this. So I checked the angle. The angle is wire chip is in the two lumen. So I put the microcaster, and this is Corsair. Corsair can pass the region, and the regular wire is go to the distal every branch. So and then I dilated by the relay. This is come from the thermal. It's a very new balloon. I think that this balloon is one of the most promising balloon for the CTO intervention. So the relays can easily go past the region, dilate, and this is angiogram. So that you can see some distal region in the proximal CTO side. So I decided the 3 stent, one of the distal RCA. Yeah, I don't need the IBUS. So this is a Archmaster 2.523, 24. And then the proximal side, I put the stent, the 3U and the 3.5 stents from here. Because between this portion is quite normal with IBUS findings, so that we don't need to put the stents. We don't need the full metal jacket for this case. So I put the 3028 Archmaster. I put the 1, and the proximal side is I use a 3.5 the Archmaster 24 again, like this. But anyway, is after recolonization, you can see the very good flow. The post dilatation. This is final shot for the right coronary. Also, our concern about the LED oscillator. So we checked the FFR, but the IFR is show us is the almost 0.99, almost 1. So you can see the 75% stenosis, but today there is no ischemia of the LED oscillator, so that we left it. So I finished the case. That's all. Thank you very much.
So you did not consider road ablation? There was a lot of calcium one could see when you were trying to cross the wire initially. You got away without road ablation.
But the balloon can go, and also balloon dilatation is very nice. And the IBUS show us we can see the very much calcium, but from IBUS findings, I decided not to use the road ablation for treatment of this case.
Dr. Batra, anybody from the panel?
So the case is nicely been done by Dr. Nasu and Dr. Rishikesh, and it seems this CTO has been opened with a robotic approach, sitting in a console room and watching the case.
Thank you very much, the Bombay group.
Thank you very much.
We go back to Sanjay Gandhi again.